Hello everyone and welcome to the anatomy session. Myself Dr. Ashwini Kumar and I will be dealing with the human anatomy with you guys. Uh, let me tell you what the plan is today and tomorrow. That our first session will be all about head and neck and neuroanatomy. So I'll be starting with the head and neck first, and don't worry about the general anatomy part. General anatomy we'll do it in the last, taking all the general histo and the general anatomy portion. So this time we'll start with the head and neck, and we'll go in a slightly retrograde manner. I mean we'll start with the cranial nerve nuclei, and then we'll go to cranial nerves, followed by the dura mater, and in the last we'll go to the triangles, all the anterior and posterior triangles. The reason is because when we read all these triangles in our first year, I mean we started reading about the triangles without knowing nothing about cranial nerves or vessels of the head and neck, but this time we'll lay a foundation for the triangles and then we'll switch to them. So we're going to start with the cranial nerve nuclei first. This is one very important topic. You get a lot of questions from the cranial nerve nuclei, and then we'll go to the cranial nerves. We'll do all the cranial nerves in detail, and finally switching to the dura mater and other parts in the head and neck. So let me start with the head and neck here. So we'll be talking about all the cranial nerve nuclei and all cranial nerves. So let us begin with the cranial nerve nuclei first. Let's have a discussion on the cranial nuclei, where they are placed, what are the cranial columns we have, what nuclei will come under them, and I will tell you all possible questions which are asked, which are already asked from these topics and can be asked in future as well. So let's begin with the cranial nerve columns. See, skeletal muscle, guys, if I say we have skeletal muscle, smooth muscle and cardiac muscle. This is how we divide the muscles in three groups. But the muscles in head and neck, I mean we can divide skeletal muscle in two groups. We have two types of skeletal muscle in head and neck. We have muscles like other usual skeletal muscle we have, which are derived from somites or paraaxial mesoderm, and then we have a group of muscle which is derived from the pharyngeal arches. And because the cranial nerve columns are arranged based on what type of muscle they are supplying, if we are talking about the efferent column, so first thing we need to know about the pharyngeal arches. Just briefly about pharyngeal arches so that we can switch on to the cranial nerve columns. Now we have arch 1, 2, 3, 4 and 6. As we know that the fifth pharyngeal arch usually disappears, so these are the pharyngeal arches we have: first, second, third, fourth and sixth. I am pretty sure that you already know the nerve supply for the arches. The nerve supply for first pharyngeal arch is mandibular nerve. For second, it's facial nerve. Broadly it's mandibular nerve, although it's not only mandibular, we also have chorda tympani, but mandibular nerve for the first, second arch facial nerve. Third arch is supplied by glossopharyngeal nerve, and let me say collectively fourth and sixth arch are by vagus. Although different branches of vagus, the superior laryngeal and recurrent laryngeal, but let's say these are the, broadly we are saying first arch is the nerve supply is mandibular nerve, for the second facial, third glossopharyngeal, fourth and sixth is vagus. Mandibular nerve supplies what muscle? I mean first we need to see what are these skeletal muscles which are supplied in these pharyngeal arch column. Mandibular arch supplies muscles of mastication, muscles of mastication. When we'll talk about mandibular nerve, we'll see there are many other muscles which are supplied by mandibular nerve apart from muscles of mastication, but right now let's stick to the muscles of mastication broadly. Facial nerve supplies muscles of facial expression. Glossopharyngeal nerve supplies only one muscle, that is stylopharyngeus, and vagus nerve will supply all other muscles of palate, pharynx and larynx. So basically I can say that glossopharyngeal and vagus nerve collectively they supply muscles of palate, pharynx and larynx. Muscles of palate, pharynx and larynx. Now what I am trying to say from here is that muscles of mastication, facial expression, palate, pharynx and larynx, These are the skeletal muscles in head and neck which are derived from pharyngeal arches. We said we have two types of skeletal muscle. One is this, and another group of skeletal muscle which is derived from somites, or you can say somatic muscles in head and neck. So what is left? I mean, we are done with muscles of mastication, facial expression, palate, pharynx and larynx. So just think about this in this region, what is left? What other skeletal muscles do we have here? Now we have extraocular muscle which are also skeletal, and tongue muscles. So somatic muscles are tongue muscles, and extraocular muscles. So this is the first and the very important thing we need to know, that we have two types of muscles here, two types of skeletal muscles in head and neck, pharyngeal arch muscles and the muscles which are derived from somites. Why I am telling you this before talking about the cranial nerve nuclei, because these muscles will be supplied by the different set of cranial nerve nuclei, or you can say they are supplied by the different cranial nerve column. So in the head and neck, if I have to supply something, if I have to give the efferent, now I need to give efferent to three type of structures, guys. One, we have to supply the skeletal muscle which are derived from pharyngeal arches. Then we have to supply the skeletal muscles which are non-pharyngeal arch, that is from, you can say from the somites, and then we have smooth muscles and glands. So we have three efferent columns which we will now talk about. So keep that in mind, that we have two types of skeletal muscles, and then we have smooth muscles to be supplied in the head and neck. Although we will talk about this neural tube in detail in the embryology, now let's talk about the neural tube briefly so that we can see what cranial nerve nuclei will develop in this. Now if this is a neural tube, guys, as we all know, neural tube is an ectodermal structure which will give rise to the central nervous system. Now neural tube can be divided in two parts by a sulcus inside. That sulcus is called as sulcus limitans. The sulcus limitans divide the neural tube in two parts. The dorsal part of the neural tube is called as the alar plate, and the ventral part of neural tube is called as basal plate. Alar plate and basal plate, the two part of the neural tube. Now imagine you are looking at a spinal cord. I mean, this is neural tube only, but just think about the spinal cord for a second. Now if this is a spinal cord here, alar plate is actually representing the dorsal horn of spinal cord, and basal plate is representing the ventral horn of spinal cord. In other words, I can say that alar plate is representing the sensory part and the basal plate is representing the motor part. So all the cranial nerve columns which will develop in the basal part will be motor or will be efferent columns. Efferent columns will develop into the basal, and afferent columns will develop into the alar plate. A for alar plate, A for afferent, just to remember it. So one simple straight question which is asked many times, they will give you four cranial nerve nuclei and may ask you that which of them is derived from the alar plate and which of them from the basal plate. All you have to decide whether it is sensory or motor. Now let me throw a few examples to you. Now just tell me. If I say hypoglossal nucleus, guys, see, hypoglossal nucleus is what type of nucleus? Is it sensory or is it motor? It's a motor nucleus. It supplies muscles of tongue. So it will be derived from where? Alar or basal plate? It will be from basal plate because it's a motor nuclei. If I say abducens nucleus, again abducens nucleus is motor nucleus from the basal plate. If I say nucleus of tractus solitarius, the nucleus of tractus solitarius is for taste sensation, sensory nucleus, so will be derived from the alar plate. So when you look at your question bank, you will find many questions regarding this, that which of the following cranial nerve nuclei is from the basal and which is from the alar plate. So the only thing you have to decide whether it is sensory or it is motor. Similar type of cranial nerve nuclei form a column that is called as cranial nerve column. Now we have three efferent columns here, and let's say these are the three afferent columns, although we have more than three, but we'll talk about that. So let's say these are the three efferent and three afferent columns, namely this is GSE, that is general somatic efferent, SVE, special visceral efferent, and GVE, general visceral efferent. There is nothing to mug it up. I mean, it all makes sense if you just look at them carefully, guys. GSE, SVE, GVE. A lot of questions are asked from these cranial nerve columns. Now let's take them one by one. Let's elaborate and understand them. What does SVE stands for? SVE means special visceral efferent. Whenever you say word special visceral in the efferent column, whenever you say special visceral in the efferent column, that actually denotes branchial arches. So obviously this column is for the muscles which are derived from branchial arches or pharyngeal arches. So SVE column is for the muscles derived from branchial arches, which we already are done with, that is muscles of mastication, facial expression, palate, pharynx and larynx. So all those muscles which are derived from the pharyngeal arches will be supplied by the column that is SVE, or in other words, the nuclei which will come under SVE will supply the muscles of pharyngeal arches. That we'll see. GSE, general somatic efferent. The word that we need to catch here is somatic. What are the only somatic muscles we talked about? The only somatic muscle in head and neck are extraocular and tongue muscles. So the muscles derived from somites or somatomere, occipital somites, and those are extraocular and tongue muscles. That means all the cranial nuclei which are supplying the extraocular muscle and tongue muscle, they will come under GSE column. Make sure you underline or highlight the word S here. The word S is for somatic, which will help you remember that somatic muscles are nothing but extraocular and tongue muscle. Now extraocular muscles are supplied by what nuclei? 3, 4 and 6, and tongue muscle by hypoglossal. So 3, 4, 6 and 12. 3, 4, 6 and 12. These are the cranial nerve nuclei which will come under GSE column, general somatic efferent column. We'll talk about them in detail when we'll draw the columns. So guys, see what is similar about these two columns. What is common about these two columns? The common thing in these two columns is that they both are supplying what type of muscle? Skeletal muscle. Skeletal muscles derived from branchial arches, skeletal muscles which are derived from the somites. Now we have to supply the smooth muscles, and there comes the general visceral efferent column. General viscera. General visceral efferent is for the smooth muscles and glands. Smooth muscles and gland. Whatever smooth muscle it is, whether it is the smooth muscle of the eyeball or the smooth muscle in the gut wall, or any gland you're talking about, lacrimal, parotid, submandibular, gastric, respiratory, any gland we are talking about, all these glands and smooth muscles, they are all supplied by GVE column. So these are the first three columns, first three efferent columns we have. GSE, general somatic efferent. The word is somatic here. Somatic denotes the extraocular and tongue muscle only, the only somatic muscles in head and neck. SVE is for special visceral. Special viscera denotes the word branchial arch. The word special viscera, whenever you think of special visceral in the efferent column, that means branchial arches. So muscle derived from branchial arches, which are the muscles of mastication, facial expression, palate, pharynx and larynx. And we're done with skeletal muscles. Now it's about smooth muscles and gland, and all smooth muscles and gland are supplied by GVE column. Well, this is about the efferent column. These are three types of efferent column. Coming to the afferent columns here, now we have corresponding afferent column. If this is GVE here, this will be GVA, general visceral afferent. We have SVE here, this is SVA, special visceral afferent, and GSE we have this GSA, general somatic afferent. Once again, let's take them one by one, let's understand them, and then we'll write what will come under them. GVA, guys, what is GVA stands for? GVA is general visceral afferent. General visceral. Now let us say you are having a cup of coffee. The temperature of the coffee is a general sensation, but the taste of the coffee is a special sensation. So all the general sensation which are coming from the viscera, whatever the general sensation is. I mean, general sensation can be temperature, pain, pressure, all these are general sensation, will go into GVA column. But the important thing to remember here is viscera, the general sensation coming from the viscera only. So GVA is general visceral afferent, which is carrying all the general sensation from viscera, from visceral organ. And there comes the special visceral afferent. We said the special sensation we are talking about here, that is special sensation from the viscera. Special sensation from viscera, and we are only talking about taste here. Special sensation from viscera, and we are only talking about taste. Why only taste? I mean, taste is not the only special sensation. Hearing is a special sensation, vision is a special sensation, olfaction is a special sensation. But guys, we are talking about the cranial nerve nuclei. We do not have cranial nerve nuclei for olfactory or for optic. These are the sensations which are definitely, they are special sensations, but we do not have cranial nerve nuclei for them. So olfaction is, yes, it is a visceral, special visceral type of sensation, but actually it is not coming from the cranial nerve nuclei, or it is not having the cranial nerve nuclei, so we are not including into the SVA column here. We will talk about all those type of sensation, olfaction and optic, in the neuro part, or in the neuroanatomy. Now look at these two. Now what is common about these two? What is common about SVA and GVA? The common about SVA and GVA is this V, that is visceral. We talked about the general sensation from the viscera, the temperature of the coffee, and we said special sensation from the viscera, that is taste. It can be any general sensation, and the special sensation we are only talking about is taste here. Now even if I say I am feeling my stomach is distended today, that distension of stomach feeling is also a general sensation which is coming through vagus nerve, will go into GVA column. Coming to GSA column here, the GSA, the word is general somatic afferent. Now this time, first type of sensation we are talking about is general sensation, but where from? From the somatic structure, from the body wall. All the general sensation from the body wall will go into this column, and the best example is the trigeminal nerve. My trigeminal nerve carry everything from my face. I mean, pain, temperature, touch, pressure, everything from my face goes through the trigeminal nerve. So the trigeminal nerve will come under GSA column, which we will talk about. So GSA column basically is for the general sensation from body wall. General sensation from the body wall, and in head and neck the obvious example is the trigeminal nerve. So this is about the efferent and afferent columns we have. We will add something more to it when we will discuss about the cranial nerve columns. Now let me quickly go through this once again, and then I will fetch out these columns. This is one very important topic, guys. GSE, SVE, GVE. Now I usually start with SVE, because SVE, first tell me about pharyngeal arches. So SVE, the word is special visceral, it about pharyngeal arch or branchial arch. All the muscles from pharyngeal arch will come under SVE column. Rest of the muscles, rest of the skeletal muscles in head and neck, that is we have extraocular and tongue muscles, these are the somatic muscles, so they are under which column? They are in GSE column. They are supplied by those nuclei which will come under general somatic efferent column. Both are about the skeletal muscle. GVE is about general viscera, that is smooth muscles and gland. All the nerves supplying smooth muscles and gland. I mean, facial nerve supplies the gland, it supplies submandibular, sublingual gland, lacrimal gland. So that will come under GVE, that portion will come under GVE, and we have this glossopharyngeal nerve supplying parotid gland, again GVE. Corresponding afferent column, GVE we have GVA, SVE we have SVA, GSE we have GSA. GVE and GVA. GVA is what? It is for general visceral afferent, that is general sensation, but from where? From the viscera. Special sensation of taste, SVA, again from where? From viscera. So both these are for the visceral organ. And GSA, the general somatic afferent, the general sensation, but not from the visceral organ, but from the somatic structure, that is from the body wall. Okay, now this is a circular neural tube. Now look at me. If this is a neural tube like this, in this way, and we have this alar plate and basal plate like this is a circular neural tube. Now if I say the neural tube is going to form the spinal cord, it makes sense to me. Spinal cord is also circular, and we have this neural tube we have this space inside which will form the central canal of the spinal cord. But if I say the neural tube is also going to form the, let's say, brainstem, then you cannot have this kind of arrangement. Brainstem is not having central canal. I mean, there is a central canal in the medulla, in the medullary part, but we also have the fourth ventricle into the brainstem. So when there is a fourth ventricle inside, the neural tube has to open up, the neural tube has to expand, and in the expansion of this neural tube, the LR plate will shift toward what side? Lateral side. Now look at this. This LR in the basal plate. This thing is forming the neural tube, and the neural tube is forming this brainstem. And when the brainstem will be formed, and there is a fourth ventricle accommodated inside, the LR plate will be stretched to the lateral side, which tells me that my sensory nuclei are now shifted toward the lateral side, and my motor nuclei are toward the medial side. LR plate is sensory, basal plate is motor, and that is why when you look at the lateral and medial medullary syndrome, and not only these lateral and medial medullary syndrome, but when you look at the syndromes of the brainstem, if there is an injury to the middle part of the brainstem or to the medial part of the brainstem, usually there is a sensory deficit, there is a motor deficit, because most of the motor structures or motor nuclei are toward the midline. The oculomotor nucleus, the trochlear nucleus, the abducens nucleus, the hypoglossal nucleus, all these nucleus are very close to the midline because they are all derived from what plate? From the basal plate. LR plate, most of the sensory nuclei or sensory structures. Trigeminal nuclei is through the lateral part. Nucleus, the one which is supplying nucleus of tractus solitarius, is also toward the lateral part, which is involved in the lateral medullary syndrome. So some correlation between this embryology and the clinical part here, that we have when the injury is to the middle part of the brainstem or the medial part of brainstem, it usually causes the motor deficit, and toward the lateral side causes a sensory deficit, although it's not applicable in everything, but in most of the cases. Now let's put all these cranial nerve nuclei, or column I should say, into the brainstem and see what nuclei will come under them. So I'm going to suggest you take a fresh page for this, and preferably horizontally. Now we're going to make a brainstem chart here and see what cranial nerve nuclei will come under these columns. So let's say this is starting from here. Let's say this is the, divide the brainstem in three parts here. We have midbrain, there we have pons, and that is medulla oblongata. This is the first column, second and third column. We'll keep on adding the columns, so I'm just starting with the three columns first, and you're going to tell me what are the three first efferent nuclei, or the first three efferent columns starting from the basal part. So tell me what is the first efferent column we have there. The first efferent column is general somatic efferent, the next one was special visceral efferent, and then we have general visceral efferent. These are the first three efferent columns. General somatic efferent, reminding you again what is general somatic efferent. Somatic word is for the somatic muscles, and the only somatic muscles are extraocular and tongue muscle, and extraocular muscles are supplied by what nerve? 3, 4 and 6. Third and the fourth nuclei. Third and the fourth nuclei, the motor nucleus of oculomotor and the motor nucleus of trochlear nerve, they are present in midbrain. Abducens nucleus is in the pons. 3, 4 and 6 for extraocular muscle. Tongue muscles are supplied by hypoglossal nucleus, and we have this huge hypoglossal nucleus which is in medulla oblongata. That is all about GSE column. General somatic efferent, that is extraocular and tongue muscle, 3, 4, 6 and 12. Special visceral efferent. Special viscera, what was that? We are talking about pharyngeal arches. Pharyngeal arches, and what was the nerve for pharyngeal arches, guys? What is the nerve for first pharyngeal arch? It was mandibular nerve, and for the second pharyngeal arch it was facial nerve. So we have motor nucleus of mandibular nerve and motor nucleus of facial, both present in pons. What is the nerve for third pharyngeal arch, fourth and sixth pharyngeal arch? The nerve for third pharyngeal arch is glossopharyngeal nerve. For fourth and sixth, it's the vagus nerve. And see, I'm adding here cranial accessory as well. 9th, 10th and 11th. Why 11th? We'll talk about that. This is called as nucleus ambiguous. This is called as nucleus ambiguous. This collective nuclei of 9, 10 and 11 is called as nucleus ambiguous. 9 and 10, understood. These are the nerves of pharyngeal arches, so we can 9 and 10. Mandibular, facial, glossopharyngeal and vagus. Why accessory, guys? This is actually cranial accessory we are talking about. Why cranial accessory nerve is counted in this column? SVE column is for pharyngeal arches, and we never said that cranial accessory nerve is the nerve for pharyngeal arch, and we are still including it into the SVE column. Now I'll put it like this, I mean cranial accessory nerve, I would say it's the most unfortunate nerve in head and neck. It does a lot, but the credit goes to vagus only. The reason is cranial accessory nerve comes out of the jugular foramen, and if this is a vagus nerve, it joins with the vagus nerve. So whatever is supplied by the cranial accessory is actually via vagus, and this phenomena is called as hitch and hiking. You hitch and hike, you just join the nerve and you hike along with it, you just go along with it and supply the structure. Muscles of palate and pharynx are actually supplied by cranial accessory nerve, but not directly, via vagus nerve, and that's why this combination is called as VAC, vago accessory complex. Do write it somewhere, VAC. This is vago accessory complex, vago and accessory complex. This complex is the one which supplies the muscles of palate and pharynx, with certain exceptions which we'll talk about. So nucleus ambiguous, combination of 9, 10 and 11, VAC, vago accessory complex. Please also note that nucleus ambiguous, because it is supplying the muscles of palate, pharynx and larynx, so if there is injury to nucleus ambiguous, it will lead to ipsilateral bulbar paralysis and loss of which reflex? These two nerves are for what reflex, guys? This is for gag reflex. So please note, injury to nucleus ambiguous will lead to ipsilateral bulbar paralysis, although it won't be a complete bulbar paralysis because trunk muscles are still saved in that case. So injury to nucleus ambiguous, it is ipsilateral bulbar paralysis and loss of gag reflex because of these two nerves. So this is about the GAC column and SVE column, the two columns which are about skeletal muscles. Now let's come to the column that is GVE, general visceral efferent. The column is about the smooth muscles and glands. Let's take the glands first, and in the glands let's talk about salivary glands first. Salivary glands are supplied by the set of nucleus both present in the pons called as superior salivatory nucleus. This is superior salivatory nucleus and inferior salivatory nucleus. We have a superior salivatory nucleus and inferior salivatory nucleus. Superior salivatory and inferior salivatory. Their name and their function is kind of opposite. Superior salivatory nucleus will supply the gland below, and the inferior salivatory will supply the gland above. So the name is superior salivatory, but it is supplying the gland below, that is submandibular and sublingual gland, and inferior salivatory is supplying the gland above, that is parotid gland. Just make sure to write it somewhere that superior salivatory nucleus is for submandibular and sublingual. You can remember this by these two S also. Superior salivatory nucleus, submandibular and sublingual gland, and inferior salivatory for parotid. Now in AIPG they even asked the question that lacrimal gland is supplied by what nucleus, and lacrimatory nucleus was not in the option. If the question says lacrimal gland is supplied by what nucleus, then you will go with the superior salivatory nucleus only. Why? Because the caudal part of superior salivatory nucleus is nothing but lacrimatory nucleus. The caudal part of superior salivatory nucleus is called as lacrimatory nucleus, or you can say this is fused with the superior salivatory nucleus caudally. So superior salivatory nucleus, now we can say in total it is supplying what? Submandibular, sublingual as well as lacrimal gland via facial nerve, which we will talk about. So these are the two superior and the inferior salivatory nucleus which are present in the pons. In the medulla we have a nucleus here. This is called as dorsal nucleus of vagus. As the name suggests, dorsal nucleus of vagus, it is pushed dorsally into the floor of the fourth ventricle. This is called as dorsal nucleus of vagus. Dorsal nucleus of vagus will supply the muscles, the smooth muscles in the GIT and respiratory along with the glands over there. So all the GIT and respiratory smooth muscles and their glands, they are supplied by the vagus nerve, which is starting from the dorsal nucleus of vagus. Now there is one more thing which is missing from this column, guys. GVE column is also having a nuclei which will supply the smooth muscles in the eyeball, and the smooth muscle we are talking about is sphincter pupillae and ciliaris. So sphincter pupillae and ciliaris is supplied by this nucleus which is called as Edinger-Westphal nucleus. Edinger-Westphal nucleus supplies sphincter pupillae and ciliaris again by hitchhiking via the third nerve. There is no nerve called as Edinger-Westphal nerve. So Edinger-Westphal will reach the sphincter pupillae and ciliaris muscle using third nerve or oculomotor nerve, which again we will talk about later in this section. So this is about the efferent column first. We have the efferent column which supplies the skeletal muscles derived from the somites. We have column which supplies the skeletal muscles derived from pharyngeal arches. As you can see, these are the nerves for pharyngeal arches: mandibular, facial, glossopharyngeal, vagus, and as I told you, cranial accessory supplies certain muscles using vagus nerve only. General visceral efferent is about smooth muscles and gland. Superior inferior salivatory nucleus, the name and function is kind of opposite. The superior salivatory is for the submandibular and sublingual gland along with lacrimal gland, because lacrimatory nucleus is a caudal part of superior salivatory, and inferior salivatory supplying the parotid gland. Dorsal nucleus of vagus taking care of smooth muscles and gland in the GIT and respiratory till midgut, and then we have Edinger-Westphal which is supplying the sphincter pupillae and ciliaris. Now this also is an important column for the exam point of view, because they ask questions regarding there are many questions which can be framed from this. Like I already told you the question about the lacrimatory nucleus. Now another question they ask from this is that how many cranial nerves are parasympathetic? Guys, when you say sympathetic and parasympathetic outflow is craniosacral outflow and sympathetic outflow is thoracolumbar outflow. That means thoracic and lumbar nerves, these are the spinal nerves, they can form the sympathetic component, but parasympathetic nerves either are the cranial nerves or they are the sacral nerve, S2, S3 and S4. But we have 12 pair of cranial nerves. All 12 cranial nerves are not parasympathetic. Only those cranial nerves are parasympathetic which are either supplying some smooth muscle or they are supplying some gland, and these nucleus will tell about those nerves. Edinger-Westphal will reach its destination, that is sphincter pupillae and ciliaris, via which nerve? Third nerve. So third nerve becomes what? Parasympathetic nerve. Superior salivatory nucleus supplying submandibular, sublingual and lacrimal gland using what nerve? Facial nerve. So facial nerve becomes parasympathetic. Inferior salivatory nucleus supplies parotid gland using glossopharyngeal nerve, which again is the parasympathetic nerve, and needless to say this is nothing but vagus nerve here. 3, 7, 9 and 10. Please note 3, 7, 9 and 10. These are 4 cranial nerves which are parasympathetic as well. 3, 7, 9 and 10. The 4 cranial nerves which are parasympathetic. 3, 7, 9 and 10. 4 cranial nerves which are parasympathetic. And that is why GVE column is also called as parasympathetic column. That is why GVE column is also referred as parasympathetic column, because it is carrying all those nuclei which will supply, which will have all the connection to those nerves which are parasympathetic. Smooth muscles and glands are supplied by the autonomic nervous system. So GVE column is also called as parasympathetic column. Well, this is about the efferent column here. This is about the efferent column. Coming to the afferent columns, as we said, we have corresponding afferent column. The first catch is that GVE, GVA, I'm sorry, corresponding afferent. So GVE, we have GVA and SVA, they both are together. We need to keep GVA and SVA together. I'll tell you how, why. And we have this GSE, so we'll have a GSA, general somatic afferent here. GVA and SVA together. What does it mean first of all? See, it means that there is one nuclei which is doing both the function. It is doing this function as well as this function. It is responsible for general sensation from the viscera as well as taste sensation from the viscera. It means there is one nuclei which is carrying the taste of the coffee, it is also carrying the temperature from the coffee. And that column, this unique thing about this column is that it is alone in the entire, this column here, this is the only nuclei in this entire column. There is nothing above and nothing below it, and that's why we call it nucleus of Tractus solitarius. Nucleus of Tractus solitarius. It's a solitary nucleus. It's the only nucleus in the entire column. That's why we call it nucleus of Tractus solitarius. And the cranial part of this nucleus of Tractus solitarius is gustatory. I'm writing G here. G is not for GVA. G is for SVA actually, and G represents the gustatory. Taste sensation will go into the cranial part. That means the cranial part of this nucleus is SVA, and caudal part of rest of the caudal part of this nucleus is GVA. Taste of the coffee is going into the cranial part, and all the general sensation, pain, temperature, touch, pressure from the viscera, they are going into this caudal part of this nucleus of Tractus solitarius. So one function, one nucleus having two different type of function, carrying general as well as special sensation, and that's why we call it nucleus of Tractus solitarius. Now this nucleus took care of both the type of sensation, general as well as special, but the thing is from where? From the viscera. We need to talk about the general sensation which are coming from the body wall, and I told you the example, the best example here is the trigeminal nerve, and that's why the nuclei which is present here, the nucleus which is present here is also called as trigeminal nuclei, which is having three components. This huge nucleus here is called as the trigeminal nuclei. We have three parts of this trigeminal nuclei. The cranial part of this nuclei which is present in midbrain, this is referred as mesencephalic nucleus. The portion of the nuclei which is present in pons, this is called as principal sensory or chief sensory nucleus. Principal sensory or chief sensory nucleus, and this portion of the nuclei is actually extending to the spinal cord, to the C3 level of cervical spinal cord, and that's why we refer it spinal nucleus of trigeminal. Mesencephalic nucleus of trigeminal, chief sensory nucleus of trigeminal, spinal nucleus of trigeminal. As I told you why we call it spinal nucleus, although it is present in medulla oblongata, we call it spinal nucleus because it is going from the medulla oblongata and extending till the C3 level of the spinal cord. The question is why 3? I mean, why do we have 3 columns here? See, it's a simple math here. If you look at the tracts which are present at the spinal cord level, I mean, if you do a sectioning of the spinal cord, and if I ask you what are the major ascending tract we have, then we have a spinothalamic tract, we have a dorsal column tract, we have spinocerebellar tracts. That means we have a different tract for different functions. We have a tract for pain and temperature, we have tract for touch and pressure, we have tract for touch and pressure, pain and temperature, and proprioception. In the head and neck, my trigeminal nerve is doing everything. I mean, let's say if ophthalmic nerve, which is supplying my forehead, it will carry everything from my forehead, the pain, the temperature, touch, pressure, proprioception, everything. But there should be at least different nuclei in the brainstem where they will relay. Mesencephalic nucleus, please note, mesencephalic nucleus is for proprioception. Mesencephalic nucleus is for proprioception. So all proprioceptive information from the face will go into the mesencephalic nucleus via trigeminal nerve. Chief sensory nucleus is for touch and pressure. and spinal nucleus is mainly for pain and temperature. Proprioception, touch and pressure, pain and temperature. Proprioception into the mesencephalic nucleus, chief sensory nucleus is for touch and pressure, and spinal nucleus is for pain and temperature. Please also note a few important things about this mesencephalic nucleus. Now let me tell you the question which was asked from this and how we go about it. The question which was asked in the in AIPG 2009, if I'm correct, the question was that what is the nucleus for mesenteric reflex or jaw reflex. Now guys, deep tendon reflex, I mean let's take an example of patellar reflex. If you're tapping a patellar tendon, then what actually you are sending inside for which the reflex is coming out? You are sending in the proprioception. You're sending in the stretch reflex. So when you tap a patellar tendon, so there is a the nucleus which is present inside, which will give a response over there, should be responsible for the proprioception. The same thing in here. In head and neck, the proprioceptive nucleus in the entire head and neck is mesencephalic nucleus. So in jaw reflex, the response is coming from the mesencephalic nucleus only. So mesenteric reflex or jaw reflex or any deep tendon reflex in head and neck, although it is only mesenteric here, the nucleus will be mesencephalic. And mesencephalic nucleus is also the only site in entire CNS which is having unipolar neurons. Mesencephalic nucleus is the nucleus for mesenteric reflex. If you are writing, it is a nucleus for mesenteric reflex or jaw reflex, and it is the only site in the CNS with unipolar neurons. It is the only site in CNS with unipolar neurons. All deep tendon reflexes are monosynaptic reflexes, which makes sense. I mean that's why this is the site for unipolar neurons. So guys, these are the three efferent columns and we have three afferent columns in here. Now we said we have three efferent and three afferent, but adding to this there is actually one more. You can add one more column to this. If you don't have space, you can write it on the next page there, and that column is SSA. Something odd about this column. I mean SSA. What does SSA stands for? It is special somatic afferent. Special somatic afferent. We are using this special word with the somatic for the first time. Every time when we say that special, it was with visceral, special visceral, special visceral. Now we are saying special but yet somatic, special somatic afferent. What does it mean actually? It means special somatic afferent means that sensation is coming from the structure which is developmentally somatic, but the sensation is special. A special sensation from the somatic structure. Internal ear, olfactory mucosa, these are somatic structures. Sensation coming from them, olfaction, hearing, vision, all these are special sensation. But out of the olfaction, vision and hearing and balancing, it's only hearing and balancing which are having cranial nerve nuclei. We do not have cranial nerve nuclei, as we already said, for olfactory and optic nerve, but we do have cranial nerve nuclei for hearing and balancing, that is vestibulocochlear. So vestibulocochlear nerve are the only, vestibulocochlear nuclei are the only nuclei which will come under SSA column. And where they are present at the pontomedullary junction. So at the pontomedullary junction we have this vestibular nucleus, and the C is for cochlear nucleus. Vestibulocochlear nucleus, the nuclei which are carrying the sensation, special sensation from those structures which are developmentally somatic. That's why SSA, special somatic afferent. So guys, this is about the efferent and the afferent columns. Now let me give you a few examples of the type of questions which are asked from this, and you yourself try these to answer these questions and keep writing them. Okay, my first question to you is, which is already asked in AIPG. The question was that how many nuclei do we have for trigeminal nerve? How many nuclei do we have for trigeminal nerve? Now whenever we think of trigeminal nerve, the 3 comes to our mind. Trigeminal means 3, but no, the answer is 4. How come 4? Mesencephalic nucleus chief sensory nucleus, spinal nucleus. These are three sensory nuclei. So these are the three sensory nuclei here for the trigeminal nerve, but we also have to count this one, the motor nucleus of mandibular. So we have one motor and three sensory nuclei. That means we have four nuclei for trigeminal nerve. Please note that. Please note we have four nuclei for trigeminal. We have three sensory and one motor. Another question. Now, and be very careful about this language of the question. Are they asking about the cranial nerve nuclei or they are asking about the cranial nerve columns? If the same question says how many cranial nerve columns do we have? How many cranial nerve columns? The columns is GSA, this is one column here, and SVE. So the columns are SVE and GSA. Nuclei are four, three nuclei in GSA column, one in SVE column, but the column are two, that is SVE and GSA. And remember one thing, that never go with the name of the nuclei. This is called as trigeminal nuclei. Now trigeminal nuclei doesn't mean that only trigeminal nerve can come into it. It's all about GSA. All the general somatic sensation will come into this nuclei. Doesn't matter they are coming through glossopharyngeal nerve or through vagus nerve or through facial nerve. I mean vagus nerve, it supplies the external auditory canal, that branch which is called as Arnold's nerve or Edelman's nerve, supplying the skin of the external auditory canal. Supplying the skin. Skin means somatics, and the somatic sensation, general somatic sensation goes into with what column? That is into GSA column. So although the nucleus is called as trigeminal nuclei, but other nerve can also come into it depending upon what type of sensation they are carrying. Okay, now let me make you write a few cranial nerve columns based on all these what we discussed here, the one which are important here. And let me put it in a question format only. If I ask you that how many columns do we have for oculomotor nerve? Think about it. How many columns do we have for oculomotor nerve or third nerve? One column is this for sure. You can see the motor nucleus of oculomotor nerve here. So one column is GSE. And we also said that Edinger-Westphal fibers, they will go along with which nerve? Third nerve. So we also have GVE. So please note oculomotor nerve is having two columns, GSE and GVE. The two columns for oculomotor nerve are GSE and GVE. If I say how many columns we have for trochlear nerve, only one. Trochlear nerve is only having one column, that is GSE. It is supplying this superior oblique muscle and nothing else. But if the question is about the abducen, now again there is a catch here. If the question is about abducen, how many columns do we have for abducen? It's again two. Why two? Abducen nerve is supplying lateral rectus muscle, which is a somatic muscle of head and neck. It's an extraocular muscle. So one is GSE. So abducen one column is GSE, and it is also said that abducen nerve is also carrying the proprioception from the same muscle which is supplying it, which it is supplying. That is lateral rectus. It supplies lateral rectus and it also carries proprioception from it. In a way I am saying that abducen nerve is not purely motor, although we say that abducen nucleus or abducen nerve is the purely motor nerve, but abducen nerve is also carrying the proprioception from the lateral rectus. And proprioception from the lateral rectus, I mean the word is proprioception. What is the only proprioceptive nuclei in the brainstem? That is mesencephalic. So the two columns for the abducen nerve will be, one is GSE and another one will be GSA, because it carries proprioception from the lateral rectus. We'll talk about the other major columns with the cranial nerves only when we'll discuss the glossopharyngeal, vagus and facial nerve. We'll talk about which column all these nerves possess. So on that note, let's start with the cranial nerve and we'll start with the oculomotor nerve, because first and second nerve, as I said, the first and second nerve, they do not have cranial nerve nuclei, they are all related to the nervous system only. We'll talk about them in the neuro. So let's start with the third nerve. So we'll begin our discussion on the cranial nerves and we are starting with the third nerve or oculomotor nerve. So there we go, and you're going to help me out in this. You first tell me where exactly was the third nerve nuclei, guys. Motor nucleus of oculomotor nerve is present where? I mean, which part of the brainstem? Was it in midbrain, in pons, or medulla? It was in midbrain. It was in midbrain. So let's say if this is a section of the midbrain here. Now from the midbrain, that is in the posterior cranial fossa, for any nerve to start from the posterior cranial fossa and to supply the structure in the orbit, now what are the two major structure it has to go through, or it is related to? Now when the nerve goes forward, it first will be related to the cavernous sinus, and then it goes inside the orbit through a fissure, that is superior orbital fissure. So let me make a plot here. If this is the midbrain here, if this is a section of the midbrain, from the level of superior colliculus, because we are talking about third nerve and third nucleus is present at the level of superior colliculus, so it's a section of the midbrain at the level of superior colliculus, and let's say this is the midline here dividing into the right and the left. There we have cavernous sinus, this is a superior orbital fissure. I'm just writing SOF, this is superior orbital fissure, and there we have the muscles which are to be supplied in the eyeball, the muscle which are to be supplied by third nerve, that famous mnemonic we know it from first year, except SO4 and LR6. So the muscles to be supplied are LPS, levator palpebrae superioris, superior rectus, medial rectus, inferior rectus, and inferior oblique. There is no superior oblique here and no lateral rectus. They are supplied by fourth and sixth nerve. So LPS, SR, MR, IR, and IO, the muscle which are to be supplied. Now there is something unique about this oculomotor nucleus, and based on which they even asked the question in AIIMS 2013 November. The oculomotor nucleus, they fuse in the midline. Both right and the left oculomotor nucleus, they ventrally fuse in the midline. They ventrally fuse in the midline, and let's say if this is an oculomotor nerve starting from here, this oculomotor nerve will go through the lateral wall of the cavernous sinus, and before entering into superior orbital fissure, it divides into upper division and lower division. It divides into upper and lower division. The upper division will go and supply upper two muscle, that is superior rectus and LPS, whereas lower division will go in and supply medial rectus, inferior rectus, and inferior oblique. So this is first thing about the oculomotor nerve. The nerve passes from the lateral wall of cavernous sinus, it is related to the lateral wall of cavernous sinus, it enters the orbit through superior orbital fissure, divides into upper and lower division. As the name suggests, upper division supplies upper two muscle which are LPS and SR, and lower division supply rest of the three muscles here. More important thing here is that how Edinger-Westphal nucleus, which will run with the oculomotor nerve, supplies sphincter pupillae and ciliaris. Now guys, let's say if this is Edinger-Westphal nucleus, I mean we have Edinger-Westphal nucleus also here. So schematically, let's say this is Edinger-Westphal nucleus. The Edinger-Westphal nucleus, this will hitchhike with this oculomotor nerve, then with the lower division, then with the nerve to inferior oblique, and finally they get separated to relay into the only ganglion or only parasympathetic ganglion we have in the orbit, that is ciliary ganglion. The only parasympathetic ganglion there, we have the ciliary ganglion. Now this is important, how Edinger-Westphal is reaching the ciliary ganglion using third nerve, lower division and nerve to inferior oblique, guys. This is prospective new question. They never ask this question. They ask the question regarding ciliary ganglion, about sphincter pupillae, ciliaris muscle, but I believe this is one prospective new question which they can ask, that which nerve carries the fiber to ciliary ganglion, and that is nerve to inferior oblique. It's nerve to inferior oblique which carry fiber to ciliary ganglion. The postganglionic fiber from the ciliary ganglion will supply sphincter pupillae, and ciliaris muscle. Sphincter pupillae and ciliaris muscle. And what nerve is this? What postganglionic fibers are these? Now you yourself will find it out in a couple of minutes when we'll discuss about the ganglions. So I'm putting a question mark here. We'll come back to this. The postganglionic fibers supplying sphincter pupillae and ciliaris, and which postganglionic fibers are these? Now you will decide it by yourself only. So this is about the oculomotor. The important thing about oculomotor nucleus and nerve. The nerve passes through the lateral wall of cavernous sinus. Please remember, it is from the lateral wall of cavernous sinus. It's not going through the cavernous sinus. Then dividing into upper and lower division. An important part here about the Edinger-Westphal nucleus, how it reaches the ciliary ganglion, that is using the lower division and nerve to inferior oblique. Now the question which was asked in the AIIMS, the question was that which of these four muscle is supplied by contralateral nuclei. See, options were superior rectus, medial rectus, inferior rectus and inferior oblique, and the question was which of these four muscles are supplied by the contralateral nuclei. Now when this question was asked in the AIIMS exam, many of us thought that it's a question with not correct options. Now many of us thought that superior oblique should be in the option, because superior oblique is supplied by the contralateral trochlear nuclei. But no, it's a correct question. The question says that which of those four muscle is supplied by contralateral nuclei. Now if you look at the schematic diagram, or even if you look at the diagram which are given in any textbook of anatomy, everything seems to be ipsilateral. It doesn't look like anything is crossing over to the opposite side and supplying. And there comes the shape of the nuclei into the picture. We said both these nuclei will fuse in the midline. Now let's say these are the two oculomotor nuclei which are fusing in the midline. This is one of the right side, one of the left side. Guys, remember that the fibers which are supplying superior rectus, they will cross over inside the nucleus and supply superior rectus of the opposite side. So this is how it goes. So superior rectus is the answer to this question. Superior rectus is actually supplied by the contralateral nuclei, and this is one example of intranuclear, it is an example of intranuclear decussation. The fibers which are supplying superior rectus, they are decussating inside the nucleus and then coming out. Rest of the muscles, they are supplied from the ipsilateral side only. The LPS, the medial rectus, the inferior rectus, they are all supplied by the same side. But the fibers which are for superior rectus, they actually cross over inside and they supply opposite superior rectus. So the answer to that question is superior rectus, supplied by contralateral oculomotor nuclei. Another important thing about this oculomotor nerve is that this nerve is content of interpeduncular fossa. This nerve is content of interpeduncular fossa. Third nerve is a content of interpeduncular fossa. Now there is a clinical significance for that. Yes, it is a content of interpeduncular fossa. We'll talk about this interpeduncular fossa in the neuroanatomy part. The thing is that we also have a cistern in the region of interpeduncular fossa that is called as interpeduncular cistern. Cisterns. What are cisterns, guys? Cisterns are nothing but dilated subarachnoid spaces, and we have circle of Willis in that interpeduncular cistern. Circle of Willis is having anterior and posterior communicating artery. We have the Berry aneurysm are most commonly seen in the anterior communicating or posterior communicating artery, and the rupture of Berry aneurysm, which is actually taking place in the interpeduncular cistern, will damage which nerve. They even ask this question that what is the first nerve to be involved in the intracranial aneurysm. So if there is a berry aneurysm which is in circle of Willis, if it gets ruptured, and where is circle of Willis? It is in interpeduncular cistern. And what is a nerve in interpeduncular fossa? That is third nerve. So please note, this is the first nerve to be involved in intracranial aneurysm. We will talk more about it in the neuro part. So this is the first nerve to be involved in intracranial aneurysm. First nerve to be involved in intracranial aneurysm. So third nerve is the content of interpeduncular fossa and the first nerve to be involved in intracranial aneurysm. Well, this is about the third nerve. The important thing about third nerve, what muscle it is supplying, ciliary ganglion is supplying what muscles, how the fibers are reaching the ciliary ganglion, which muscle is supplied by the contralateral nuclei, and the nerve which is most commonly involved in intracranial aneurysm. Well, let's not rub this thing because we will be needing this for cranial nerve columns only. Coming back to the next nerve, that is fourth nerve. Fourth nerve or trochlear nerve. Once again we'll draw the plot here, guys. This thing is, if this is again the right side and the left side of the section of the brainstem, now this time the section is taken from the inferior colliculus. So we have, let's say this is the fourth nuclei and this is another fourth nuclei. So unlike third nerve, they are not fusing in the midline or anything. There we got the cavernous sinus. This is the superior orbital fissure once again, and this time the only muscle to be supplied is superior oblique. SO4, the only muscle to be supplied is superior oblique. The thing about third nerve, guys, the thing about third nerve is all the questions which are asked from the third nerve is actually right in the beginning only. It will decussate and will go to the dorsal aspect of brainstem through the lateral wall of cavernous sinus and then supply the superior rectus. So this is all about the third, this fourth nerve here. Everything important, everything, all the questions which are asked from the fourth nerve is in here only. Now you think, look at this and tell me what you see here. The first important thing we note here is that this is the only nerve which is coming from the dorsal aspect of brainstem. All other cranial nerves are coming from the ventral aspect. The third nerve, the sixth nerve, fifth nerve, seventh, all are coming from ventral aspect. That's the only nerve from the dorsal aspect of brainstem. And because it is coming from the dorsal aspect of brainstem, it has to travel a very long distance to come in front. It is the nerve with the longest intracranial course. It travels very long inside the cranial cavity. So it is a nerve with the longest intracranial course. Obviously supplying contralateral superior oblique muscle because there is a decussation you can see. You can see the decussation within the brainstem, and also this is the thinnest cranial nerve or the most slender cranial nerve. Now these are all important point about the fourth nerve. One is it's the only nerve from dorsal aspect of brainstem. It's the only nerve from the dorsal aspect of brainstem. This nerve is having longest intracranial course, the nerve with the longest intracranial course. As you can see, the lower motor neurons, they decussate. Lower motor neuron decussate within brainstem, and as I said, this is the thinnest cranial nerve, thinnest or most slender, or you can say smallest cranial nerve. Now this word smallest is bit misleading. I mean, smallest can be what? I mean, smallest can be smallest in length, but if you look at the text, the smallest actually is about the thickness of the nerve. So when you say smallest cranial nerve, the question is about the thickness of the nerve. So this is thinnest cranial nerve, also called as smallest cranial nerve. When they have to ask the question regarding the length of the nerve, they will call it shortest. So shortest cranial nerve is obviously olfactory nerve. Olfactory is definitely the shortest cranial nerve. This unfortunate nerve never even got a chance to become a nerve. It starts in olfactory mucosa and through the cribriform plate into the olfactory bulb. Smallest one or slendermost or thinnest cranial nerve is trochlear only, the fourth nerve. So these are all important points about the trochlear nerve. Next in the line we have abducen. Next is abducen nerve. We are talking about the nerves which are supplying extraocular muscle. So next let's talk about the abducen, then we'll come to the fifth. Now the first and probably the most important thing for the abducen nerve is the location of the nuclei. Third and the fourth nuclei, they are present in the midbrain, and that is almost in line with the cavernous sinus. But sixth nucleus, that is abducen nucleus, will start from the pons, and pons is slightly lower obviously. So pons is lower, and then we have cavernous sinus slightly higher there. That means this time the nerve which has to start from this pons here, it has to ascend upward to reach the cavernous sinus, and then it travels through it. So make sure when you draw this, the pons is slightly lower. This is pons here. There is 6 nucleus inside, and there we have cavernous sinus. So make sure when you draw the cavernous sinus, it should be higher than the pons. So this is cavernous sinus again, superior orbital fissure, and again this time only muscle to be supplied here, that is lateral rectus, that is superior orbital fissure. Now the abducen nerve, as I said, the abducen nerve will ascend upward to reach the cavernous sinus region here, and when it ascend upward and reach there, guys, this is related to the apex of petrous temporal bone, which is quite sharp. This is apex of petrous temporal. It is related to the apex of petrous temporal bone, and at the apex of petrous temporal bone there is a ligament which is present here. I am using a blue color here because green probably won't be visible. So there is a ligamentous canal which is present close to the apex of petrous temporal bone. This canal is called as Doralow's canal. PGI 2005, the content of Doralow's canal. The content of Doralow's canal is 6th nerve or abducen nerve. So this 6th nerve or abducen nerve, it ascends upward. It is related to the apex of petrous temporal bone, which is sharp, and then it passes through a canal called as the Doralow's canal. It is a ligamentous canal made up of petroclinoid ligament, and then this nerve passes through the cavernous sinus and superior orbital fissure to supply lateral rectus. It passes through the cavernous sinus. For third nerve and fourth nerve, we said the nerves which are passing through the lateral wall. This is the nerve which actually passes through the cavernous sinus. It is the content of cavernous sinus. It's not from the lateral wall. It goes from inside the cavernous sinus along with internal carotid artery. So abducen nerve, the nucleus is in pons. It ascends upward to reach the apex of petrous temporal bone, and there comes the clinical anatomy point here. Now, what happens to the brainstem in increased intracranial pressure, guys? What is the tendency of brainstem in increased intracranial pressure? When there is increased intracranial pressure, the brainstem will try to herniate out of the cranial cavity. And what is the largest foramen we have? That is foramen magnum. So if this is brainstem here, and let's say there is a foramen magnum somewhere here below, in increased intracranial pressure, the brainstem will try to herniate outside, and when this brainstem herniate outside, the nerve which is present, again the sharp petrous temporal bone, apex of petrous temporal bone, will get stretched and will get injured. That is why abducen nerve is most commonly involved in increased intracranial pressure. It is most commonly involved in increased intracranial pressure because of its anatomy. It ascends upward and reaches the apex of petrous temporal bone, which is very sharp. So in increased intracranial pressure, the nerve will get stretched and it will be injured at this point. And please also note, this is the nerve which is having longest intradural course. Longest intradural course. This is all we need to know about this abductor nerve here, that most commonly involved in increased intracranial pressure and is the longest, it is having the longest intradural course. Intracranial course longest was for the trochlear nerve and longest intradural is for abductor nerve. So we are done with third, fourth and sixth nerve. Let us talk about the nerve, the two major nerves which will lay the foundation for the head and neck, that is the trigeminal nerve and facial nerve. And before we talk about the trigeminal nerve, I need to discuss something about the ganglions, the parasympathetic ganglions. There is one more topic which most of us don't like in head and neck, all these parasympathetic ganglions, and all these petrosal nerves, greater petrosal, deep petrosal. So let me try to sort it out. The reason that we don't like these ganglions or all these parasympathetic ganglions, because every ganglion is related to more than two nerves. I mean, you will see some other nerves, some nerve entering inside the ganglion and then some other nerve is coming out. I mean, the nerve enters as a greater petrosal nerve, but once it comes out, it is called as something else, and that's why ganglions look bit difficult. So first let's understand something about these ganglion before we go to the nerves here. Now every ganglion is having two types of connection, guys. Every ganglion, every parasympathetic ganglion is having two types of connection. One is called as topographic or morphological connection. Topographical connection. Now what is a topographical connection or what is a topographic nerve? Now imagine if this is a nerve here and there is a ganglion which is suspended to it. Whatever the nerve is, whatever the ganglion is. If a nerve fiber goes inside the ganglion and without relaying it comes outside, then this type of connection is called as topographic connection. It's a topographic nerve. It is simply hanging the ganglion, it just goes in and comes out without relaying inside the ganglion. So we call it topographic connection. What is a functional connection? Now what is a functional connection? Functional connection is, now let's say this is a topographic nerve. We already know what is a topographic nerve here. So there we go, this is a topographic nerve which is already there. The functional nerve will come from somewhere else, whatever the nuclei may be, superior salivatory, inferior salivatory, will come into the nuclei and relay over there, will come into the ganglion and relay there, and from the ganglion the postganglionic fiber will begin, and these postganglionic fiber will actually go through this topographic nerve only. Topographic nerve goes inside the ganglion, comes out. Functional nerve comes inside the ganglion, relays into the ganglion, and that's all, finished. Postganglionic fiber, how the postganglionic fiber will reach the target muscle or gland? They will reach through the nerve which is already topographically relating the ganglion. That means if you know the topographic nerve for the ganglion, you already know what fibers, you already know the postganglionic parasympathetic fibers. You getting me? Nerve goes inside, comes outside, topographic connection. Nerve comes inside the ganglion, relay over there, that is a functional nerve. But the functional nerve, as we can see, it is relaying inside the ganglion. So how the fiber will reach the target gland or target muscle? They will reach through the same nerve which is topographically connecting the ganglion. I'll give you one example here and we'll apply that example when we'll discuss these nerves. We have lingual nerve and this lingual nerve is topographically connecting the submandibular ganglion. This is one example here. We'll talk about this example in detail again. So this is a lingual nerve and this is submandibular ganglion. It is a topographic connection. Now what we all know is that cauda tympani nerve in the infratemporal fossa, it joins the lingual nerve. So the cauda tympani nerve, it joins the lingual nerve, and the reason it joins the lingual nerve because it need to relay into the submandibular ganglion. The cauda tympani nerve joins the lingual nerve, it runs along with the lingual nerve and then it relays into the submandibular ganglion, and the postganglionic fiber from the submandibular ganglion will come out through the same nerve, that is lingual nerve only, and will supply the submandibular gland, sublingual gland. Just one example to understand the topographic and functional connection. I repeat again, submandibular ganglion is topographically related to what nerve? Lingual nerve. Submandibular ganglion, what nerve is relaying inside it? That is cauda tympani, branch of facial nerve. So it is a functional nerve. This is topographic nerve, this is functional nerve. And functional nerve once relays inside, it's the responsibility of the topographic nerve to carry the postganglionic fiber to the target muscles or the target glands. In this case it is lingual nerve. Now what we can conclude from all this, there are two important points which I want you to write it down. One is that the nerve which topographically connects the ganglion, if you're writing, the nerve which topographically connects the ganglion, the nerve which topographically connects the ganglion will carry postganglionic parasympathetic fibers. Will carry postganglionic parasympathetic fibers. The nerve which topographically connects the ganglion, that is lingual nerve is topographically connecting the submandibular ganglion. So nerve which topographically connects the ganglion will carry postganglionic parasympathetic fibers. This is one point. Another important point also we need to note down that all four parasympathetic ganglions in head and neck, we have four parasympathetic ganglions in head and neck: ciliary, otic, pterygopalatine and submandibular. All four parasympathetic ganglions in head and neck are topographically related to trigeminal nerve. This is very important. All four parasympathetic ganglions of head and neck are topographically related to trigeminal nerve. All four parasympathetic ganglions of head and neck are topographically related to trigeminal nerve. We said that nerve which is topographically connecting the ganglion, that will carry postganglionic fiber, and now we are saying that the ganglions, all the ganglions are related to trigeminal nerve. That means all the postganglionic fibers are nothing but the branches of which nerve? Trigeminal nerve only. So if we are done talking about trigeminal nerve, that means we know the postganglionic fiber for all the four parasympathetic ganglions. You getting my point? Let me repeat it again. If I am saying that the ganglion, the nerve which is topographically connecting is carrying the postganglionic fiber, and all ganglions are related to what nerve? Trigeminal nerve. That means all the postganglionic fibers are branches of which nerve? Trigeminal nerve. If you look at the postganglionic fiber from ciliary, otic ganglion, pterygopalatine ganglion, all of them, they are branches of trigeminal nerve only, either ophthalmic, maxillary or mandibular nerve. That we will see. So keeping this concept of ganglion in mind, let's talk about the trigeminal nerve and let's see how all ganglions are topographically related to them. So let's start with the trigeminal, guys. We'll be doing this nerve in two parts. We'll first talk about the ophthalmic nerve and maxillary nerve in this frame here. In the next frame we'll talk about the mandibular nerve. So let us talk about the ophthalmic nerve and the maxillary nerve. Ophthalmic nerve and maxillary nerve are purely sensory, whereas mandibular nerve is a mixed nerve. So we'll talk about the mixed nerve separately there. Now let's say this is the trigeminal ganglion. I'm writing TG here. This is trigeminal ganglion or Gazarian's ganglion. Trigeminal ganglion is also called as the Gazarian's ganglion, and this trigeminal ganglion is resting in this close to the apex of petrous temporal bone. This cave is called as Meckel's cave. It's a depression in the petrous temporal bone close to the apex where we have the dura mater lying it. So we have this is called as the Meckel's cave. So trigeminal ganglion. As we said, in this frame we will be talking about ophthalmic nerve and maxillary nerve. Now we know ophthalmic nerve has to go inside the orbit, and the only way to go inside the orbit apart from the superior orbital fissure is apart from the optic canal is superior orbital fissure. Why not inferior orbital fissure? Because inferior orbital fissure is not the communication of orbit to cranial cavity, it's the communication of orbit to the infratemporal fossa. If anything has to go from here into the orbit, that will go through inferior orbital fissure, like the branches of maxillary artery or the branches of maxillary nerve if they have to go inside the orbit. But the communication of cranial cavity and orbit is either by optic canal or by superior orbital fissure. Optic canal is already occupied by the optic nerve and this one ophthalmic artery. There is no space inside, and that's why majority of the structures from the cranial cavity, if they have to go inside the orbit, they go through superior orbital fissure, be it third nerve or fourth nerve or sixth nerve or superior inferior ophthalmic vein or recurrent branch of ophthalmic artery. They are all into the superior orbital fissure. So guys, let's say this is superior orbital fissure here. This is, so there we have the superior orbital fissure. For ophthalmic nerve, and let me draw this maxilla. Now let's just say this is maxilla here. There we got maxilla with maxillary sinus. I mean, let me just draw schematically. These are the maxillary teeth, although everything looks same only. Just a schematic picture here. This is a maxilla with maxillary sinus inside, and there is superior ophthalmic superior orbital fissure. Ophthalmic nerve V1, before entering into the superior orbital fissure, it divides into three branches. It divides into three branches. Namely, frontal, nasociliary, and lacrimal. The frontal nerve, nasociliary nerve, and lacrimal nerve. So ophthalmic nerve, before entering into superior orbital fissure, it divides into frontal, nasociliary, and lacrimal nerve. Now look at this name, guys. Frontal nerve. We call it frontal nerve because ultimately it will come out and will supply the front of forehead. It will divide into two branches called a supratrochlear and supraorbital nerve, which will supply the skin of forehead and scalp. The frontal nerve, as the name suggests, will come into the front by dividing into the supratrochlear nerve, and supraorbital nerve, which supplies the skin of the forehead and scalp. Nasociliary, naso and ciliary. So let me take hold of this naso thing first. The naso is all about the ethmoidal nerve. We have the two divisions here called as anterior ethmoidal and posterior ethmoidal. We have anterior ethmoidal nerve and posterior ethmoidal nerve. The two ethmoidal nerves, which actually represents the word naso, because the ethmoidal nerve will go into cranial cavity to supply the dura mater. They will come into the nasal cavity. Naso will come into the nasal cavity, supply nasal mucosa and air sinuses. So anterior ethmoidal and posterior ethmoidal nerve. The second part of this is ciliary, nasociliary, because it is topographically related to ciliary ganglion. This is the first topographic connection we are talking about, guys. Please note that ciliary ganglion is topographically related to nasociliary nerve. Ciliary ganglion is topographically related to nasociliary nerve. which fetch me the answer to that question mark we left over there. In the third nerve we said that Edinger-Westphal fibers will go along with the nerve to inferior oblique and will relay into ciliary ganglion, and from the ciliary ganglion the post-ganglionic fiber will supply sphincter pupillae and ciliaris, and we put a question mark over there. What nerve is that? Post-ganglionic fiber from the ciliary ganglion, and we already know the rule that whatever the post-ganglionic fiber is coming from the ganglion is nothing but the topographic nerve. The topographic nerve carries the post-ganglionic fiber. What is the topographic nerve for ciliary ganglion? Nasociliary nerve, and that's why those fibers which are coming out from that ciliary ganglion and supplying sphincter pupillae and ciliaris are nothing but branches of nasociliary only, and those branches are called as short ciliary nerves. So you can simply say nasociliary. The branches which are coming out of those ganglion of that ciliary ganglion and supplying sphincter pupillae and ciliaris, those are ciliary nerves. The nerve which is topographically connecting the ganglion will also carry the post ganglionic fibers. Lacrimal nerve, obviously as the name suggests, lacrimal nerve supplies lacrimal gland. Lacrimal nerve supplies lacrimal gland, but how actually secretomotor supply to the lacrimal gland is reaching the lacrimal gland, we need to talk about that. So this is ophthalmic nerve. This is all we need to know about ophthalmic nerve here. Divides into three branches: frontal, nasociliary and lacrimal. Remember, before entering into superior orbital fissure, frontal nerve divides into supratrochlear and supraorbital, supplying forehead, skin and scalp. Nasociliary we have anterior and the posterior ethmoidal nerve, and ciliary represents the topographic connection. We said all the ganglions are topographically related to trigeminal nerve. So first one is ciliary ganglion to the nasociliary nerve. Lacrimal nerve supplies the lacrimal gland. Talking about this anterior and posterior ethmoidal nerve, they do ask questions especially on the anterior ethmoidal nerve. Now guys, as I said, ethmoidal nerve, from the orbit they go inside the cranial cavity, and from the cranial cavity they come into nasal cavity. If any nerve is going inside the cranial cavity, now what is it going to supply? You take any nerve XYZ, whether it's a branch of vagus or hypoglossal or trigeminal, mandibular, maxillary or even ophthalmic. If a nerve goes inside the cranial cavity, the intention is to supply the dura mater, and once it supplies the dura mater, then it comes into the nasal cavity. It supplies other structures like nasal mucosa and sinuses. So please note that anterior ethmoidal nerve, they ask this question that which of the following structure is not supplied by the anterior ethmoidal nerve. So the structures which are supplied by anterior ethmoidal nerve are dura of anterior cranial fossa. I am writing ACF, anterior cranial fossa, dura of anterior cranial fossa. Nasal mucosa, ethmoidal and sphenoidal air sinus. Ethmoidal and sphenoidal air sinuses. Dura of anterior cranial fossa, nasal mucosa, ethmoidal and sphenoidal air sinuses. This question was asked twice, and every time they gave the same option. Actually, the options were which of the following structure is not supplied by the anterior ethmoidal nerve, and the options were dura mater, nasal mucosa, sphenoidal air sinus and maxillary sinus. Maxillary sinus is supplied by the maxillary nerve completely, which we will talk about next. So it is supplying ethmoidal and sphenoidal air sinus. Okay, coming to the maxillary nerve here. Maxillary nerve, first it has, see, maxillary nerve is present, it starts from the posterior cranial fossa once again, and then it has to go through the middle cranial fossa, as it is having a relation with the cavernous sinus, and then it comes out of the cranial cavity. Now first understand this, maxillary nerve comes out of the cranial cavity and it comes into this infratemporal fossa. In the infratemporal fossa there is another fossa inside, and that is called as pterygopalatine fossa. So let me keep it simple, the nerve first comes out into the infratemporal fossa, and from the infratemporal fossa then it goes into the maxillary sinus, or you can say into the floor of the orbit. The nerve comes out through a foramen that is called as foramen rotundum. Let's say this is foramen rotundum here. The maxillary nerve V2, the maxillary nerve comes out of the foramen rotundum into the infratemporal fossa, and then the nerve is either you say it is running in the floor of the orbit, or you can say in the roof of the maxillary sinus. Now we call it maxillary nerve till here, and once it is present, once it is running into the floor of the orbit, we start calling it infraorbital nerve. So guys, from here, rest of the nerve, this is called as infraorbital nerve. So this is maxillary nerve till here. This is also maxillary nerve, but the continuation of this maxillary nerve in the floor of the orbit is called as infraorbital nerve, which comes out of the infraorbital foramen. There is a foramen below the orbit called as infraorbital foramen. I am just writing IOF, infraorbital foramen, and supply the skin of the cheek. The maxillary nerve topographically connects the second ganglion into the infratemporal fossa, more precisely into the pterygopalatine fossa, and this ganglion is called as PPG, that is pterygopalatine ganglion or sphenopalatine ganglion. Maxillary nerve into the pterygopalatine fossa is topographically connecting the pterygopalatine ganglion, also called as sphenopalatine ganglion. The nerve then gives off these three branches supplying the maxillary sinus. Now look at these nerves and just try to name them. Now these three branches that you are looking at, one of them is coming from behind the body, it enters into the body, and the two nerves are given in the floor of the orbit. So I can say that these two nerves are the branches of infraorbital nerve, and this one is actually a branch of maxillary nerve. Sometimes you don't have to, it's not about the right answer, it is also about the more appropriate answer. They even ask this question that middle superior alveolar nerve, this is middle superior alveolar nerve, is a branch of maxillary or infraorbital. Both are correct, but more precisely it is the branch of infraorbital. So guys, what are these nerves first of all called as? These three nerves are not only supplying the maxillary sinus, they are also supplying the superior alveoli, and that's why these are called as alveolar nerves. Posterior superior alveolar nerve, middle superior alveolar nerve, and anterior superior alveolar nerve. Posterior superior alveolar, middle superior alveolar, and anterior superior alveolar nerve, the three alveolar nerves, out of which PSAN, posterior superior alveolar nerve, is a branch of maxillary, middle superior alveolar and anterior superior alveolar are the branches of infraorbital. And as I said, they are not only supplying the maxillary sinus, these are the nerves supplying maxillary sinus, but also the superior alveoli. Now this is simply about maxillary nerve, that it is topographically relating a ganglion and giving off these three branches and all. Now there is one more important thing which I need to tell you about maxillary nerve here only, although that the significance of that nerve is in the facial. Lacrimal gland, understand this, lacrimal gland is supplied by the pterygopalatine ganglion. Now pterygopalatine ganglion has no relation to the lacrimal gland. I mean, pterygopalatine ganglion is not going or is reaching the lacrimal gland. Now how will we supply the lacrimal gland by pterygopalatine ganglion? Now what happens is, preganglionic fiber will come from somewhere else and relay into the pterygopalatine ganglion. We know the rule. We know the rule is that the functional nerve comes and it ends into the ganglion. So any functional nerve, whatever it is, which we will talk about, the nerve will come, it comes and ends into the pterygopalatine ganglion. The postganglionic fibers from the pterygopalatine ganglion, they need to reach where? Lacrimal gland. How will they reach? They will reach like this. The postganglionic fibers, guys, as we said, the first they will go to the topographic nerve. And what is the topographic nerve here? Maxillary. So postganglionic fibers first will go into the maxillary nerve. Maxillary nerve. maxillary nerve gives off a branch which is called as zygomatic nerve, and the zygomatic nerve divides into two branches called as zygomaticotemporal and zygomaticofacial nerve. Maxillary nerve gives off a branch called as zygomatic nerve, and zygomatic divides into zygomaticofacial and zygomaticotemporal. Now forget about this zygomaticofacial for now and think about zygomaticotemporal. So through maxillary nerve and through this zygomaticotemporal nerve, it goes to the lacrimal nerve, and then through the lacrimal nerve they reach the lacrimal gland. This is how postganglionic fibers from the pterygopalatine ganglion is reaching the lacrimal gland. That's why we find this the innervation of lacrimal gland, it's very difficult in first year because we are actually using three nerves to supplying lacrimal gland. The preganglionic fibers, they come from facial nerve. Postganglionic fiber are going into maxillary, and from maxillary they are going into the branch of ophthalmic, that is lacrimal. So please note the name of this connection. I mean the detail is like we have a zygomatic nerve which divides into zygomaticotemporal and facial, but just to make it easier for us, remember this connection to the lacrimal nerve, you remember the name, that is zygomaticotemporal nerve. This is zygomaticotemporal nerve. We just need to know the precise branch which is supplying it or joining with the lacrimal. So when we talk about the pterygopalatine ganglion functional connection, remember the postganglionic fibers first will go into maxillary, from maxillary it will go into zygomatic nerve se jayega into the zygomaticotemporal, and from zygomaticotemporal it goes into the lacrimal nerve, finally supplies the lacrimal gland. That's how the lacrimal gland is supplied. So this is about the ophthalmic nerve and maxillary nerve. Now let us talk about the mandibular nerve, more important. A lot of questions are asked on the mandibular nerve, and we'll again come back to the same thing when we will discuss the facial. So let's talk about the mandibular nerve. As we know, mandibular nerve is a mixed nerve, so we have a sensory root and we have a motor root. Sensory root is obviously coming from this trigeminal ganglion only. So let's say if this is a trigeminal ganglion, once again, I'm just writing it TG here, trigeminal ganglion. So the root which is coming out from trigeminal ganglion is a sensory root, and we already know we have a motor nucleus of mandibular nerve which is present in the pons SVE type. Remember, mandibular nerve is the nerve for first pharyngeal arch, so it is in which column? SVE column. So from SVE column, from the midbrain, from the pons, we have this motor root. Sensory root from trigeminal ganglion and motor root from the motor nucleus of mandibular nerve, and they both join to form this trunk of the mandibular nerve, and they both join at the level of this foramen which is called as foramen. Once again a famous mnemonic from first year, foramen ovale for male, M-A-L-E, M is mandibular nerve, so this is foramen ovale. So sensory root and motor root, they both unite to form the trunk of the mandibular nerve at the level of foramen ovale. For the PG exam point of view, the trunk of mandibular nerve is extremely important. You know, everything which is about the trunk of this mandibular nerve has already been asked in the examination. Question number 1. Which muscle of mastication is supplied by the trunk of mandibular nerve? Now nobody is going to ask you that muscles of mastication are supplied by which nerve. Now everyone knows that muscles of mastication is by mandibular nerve, but which muscle of mastication? We know we have 4 muscles of mastication, that is medial pterygoid, lateral pterygoid, temporalis and masseter. Out of these 4 muscles, which is supplied by the trunk of mandibular nerve? And that muscle is medial pterygoid. So please note, this is the first thing, this is the first one important question which is already asked, that the muscle of mastication supplied by the trunk of mandibular nerve is medial pterygoid. Not only this, the nerve which is supplying medial pterygoid The nerve which supplies medial pterygoid also supplies two tensors of head and neck, that is tensor veli palatini and tensor tympani. The nerve which is supplying medial pterygoid also supplies the two tensors of head and neck, tensor veli palatini and tensor tympani. And you know, they sometimes they twist the question. Instead of asking you that tensor veli palatini is supplied by what nerve, they will ask you tensor veli palatini is derived from which pharyngeal arch. It's a simple question actually. Pharyngeal arch is what is the first nerve for pharyngeal arch? First pharyngeal arch nerve is mandibular nerve, and mandibular nerve is supplying tensor veli palatini and tensor tympani, which tells you that these two muscles are also derived from the first pharyngeal arch. So this is one thing is medial pterygoid, second thing is about these tensors, muscles of head and neck. Third important thing about this trunk of mandibular nerve is the trunk of mandibular nerve gives off a branch which goes back into the cranial cavity through a foramen called as foramen spinosum. As I already said, if a nerve is going into the cranial cavity, the only reason is to supply the dura mater over there. So obviously this nerve is going back to supply dura mater, and this is the major nerve to supply the dura mater. Guys, the main artery supplying the dura mater is middle meningeal artery, and the main nerve supplying the dura mater is this, which is called as nervus spinosus. This is called as nervus spinosus. Called as nervus spinosus. And the same opening, the foramen spinosum, the same opening is also giving passage to middle meningeal artery. Just to remember that middle meningeal artery is also passing through foramen spinosum. So foramen spinosum, a small foramen which is just posterolateral to foramen ovale, it's a small foramen but carrying two extremely important structure, the major nerve and the major artery of the dura mater, middle meningeal artery and nervus spinosus. In certain book the nervus spinosus is, they also refer it as the recurrent meningeal branch of mandibular nerve. It is going back into the cranial cavity, so we also call it recurrent meningeal branch of mandibular nerve. One important thing, 2, 3. The fourth important thing about the mandibular nerve, and this question is even asked in AIIMS 2015, November 2015. It is topographically related to the third ganglion. We are done with till 2. This is the third ganglion which is topographically related to mandibular nerve, and that is otic ganglion. Topographically related to otic ganglion. The question was basically about the location of the otic ganglion, which I will discuss after finishing of the nerve. So otic ganglion is topographically related to mandibular nerve. After doing it all, I mean, as I said, all these are very important. They are already asked in the examination, in different examination. This was asked in the JIPMER 2014. Tensor veli palatini is derived from which pharyngeal arch? This is one state PG question of Maharashtra. And topographic collection of otic ganglion with the mandibular nerve. This was asked in AIIMS this year only. Nervus spinosus, nerve supplying the dura mater. It's a question of AIPG 2007, if I'm correct. After doing it all, the mandibular nerve now divides into anterior division and posterior division. Now this is, let's say, anterior division here, and that is posterior division. Anterior division will supply rest of the muscles of mastication. Now as we said, we have total 4 muscles of mastication. Anterior division supplies rest of the muscles of mastication. We are already done with medial pterygoid, so it will supply lateral pterygoid, temporalis, masseter. Now all these branches which are supplying these muscles, obviously these are motor branches. I am writing M here. So these are 3 motor branches coming from anterior division, and there is one sensory branch from the posterior division which is called as buccal nerve. The only sensory branch from the anterior division of mandibular nerve is buccal nerve. This is the only sensory branch, please note. And buccal nerve is one exception to the Hilton's law. Buccal nerve actually pierces the buccinator muscle supplying the skin and the mucosa of the cheek. It pierces the buccinator muscle but doesn't supply it. Buccinator is a muscle of facial expression. It is supplied by facial nerve. So though buccal branch of mandibular nerve is piercing it, but it is not supplying it. An exception in the Hilton's law. You know what is Hilton's law? If a nerve passes through a muscle, it supplies it, but not in this case. Please also note that the nerve which is supplying masseter, it also supplies TMJ. Temporomandibular joint is supplied by the masseteric nerve. The nerve supplying the masseter muscle also supplies TMJ. Coming to posterior division, posterior division, you can remember this by the mnemonic ALI. ALI, A-L-I. A is for auriculotemporal nerve. A is for auriculotemporal nerve. Auriculotemporal nerve, guys, auriculotemporal nerve, it supplies in this region. Now if I, obviously it supplies the skin of the auricle and temple region here, but apart from the skin, what other important structures are supplied by this? Now what is the gland we have here? The gland is parotid gland, and what is the joint? The joint is TMJ. So you just think of this region when you say auriculotemporal, so it supplies parotid gland and TMJ. Apart from the skin, it supplies parotid gland and TMJ. So TMJ, temporomandibular joint, is supplied by the masseteric nerve from the anterior division, and it is supplied by the auriculotemporal nerve from the posterior division. What is this loop here? Now this is one unique feature of the auriculotemporal nerve. When you will find this auriculotemporal nerve in the infratemporal fossa, you will see it looping around the middle meningeal artery, the same middle meningeal artery which is going through foramen spinosum. It's a schematic picture, so I'm drawing middle meningeal artery there and again here. But this middle meningeal artery, guys, this middle meningeal artery, you will see auriculotemporal nerve is looping around it. There is something very unique about this auriculotemporal nerve. The auriculotemporal nerve, when it goes posteriorly, it makes a loop around the middle meningeal artery and then continues its course. So A for auriculotemporal nerve. L, lingual nerve. The lingual nerve is to supply, is for the general sensation, from anterior 2/3 of the tongue. General sensation from anterior 2/3 of the tongue. Anterior 2/3 of tongue, general sensation is by lingual nerve, and taste sensation is by cauda tympani. So guys, this is lingual we are talking about, this is lingual nerve. And please also note that lingual nerve is topographically related to our fourth and the final parasympathetic ganglion of head and neck, that is submandibular ganglion. It is topographically related to submandibular ganglion. We are done with all the four ganglions topographic connection by now. Remember, ciliary ganglion to nasociliary nerve, pterygopalatine ganglion to maxillary nerve, otic ganglion to trunk of mandibular, and submandibular ganglion to the lingual nerve. The four ganglions and their topographic connection. And because you know the topographic connection, what fiber you already know? The post ganglionic fibers. And lastly we have I. I is inferior alveolar nerve. Inferior alveolar nerve, guys. Now this nerve actually goes inside the mandible. If I roughly say this is the mandible here, the nerve goes inside the mandible by passing through a foramen, or there is a canal called as mandibular canal. So it runs into the mandibular canal, and it comes out through this foramen called as mental foramen, and referred as mental nerve. Mental nerve, as the name suggests, mental nerve from the mental foramen, which will supply the skin of the chin. The skin of the chin region is supplied by the mental nerve. Now this nerve is called as inferior alveolar nerve. Now this is inferior alveolar nerve. The important thing is that the inferior alveolar nerve, before it goes inside the mandible, now before it goes inside the mandible, it gives off a branch which supply the muscle in the floor of the mouth. We have two muscles present here anteriorly in the floor of mouth. One is mylohyoid, that's why the nerve is called as nerve to mylohyoid, which is obviously supplying mylohyoid and anterior belly of digastric, and also the anterior belly of digastric, supplying the anterior belly of digastric. So inferior alveolar nerve goes inside the mandible, supply all the alveoli. The reason we call it inferior alveolar nerve, because it is supplying all the alveoli in the lower jaw. Just like we have the maxillary nerve giving off all the superior alveolar nerve, posterior superior, middle superior, anterior superior, alveolar. This is inferior alveolar nerve, which comes out of the mental foramen and becomes mental nerve, which supplies the skin of the chin. And the branch of the inferior alveolar nerve, before it enters inside the mandible, supplies two muscles in the floor of the mouth, that is mylohyoid and anterior belly of digastric. Now this is one very important nerve. A lot of questions you will find in your question bank asked from this nerve. As I already told you, the tensor veli palatini, tensor tympani, mylohyoid and anterior belly of digastric. Now these are the type of muscle they will ask you in exam. Nobody is going to ask you muscle of mastication is supplied by which nerve. But yes, the good question is about tensor veli palatini, tensor tympani, mylohyoid and anterior belly of digastric. They are supplied by which nerve? Or in other words, we can say these are the muscles which are derived from which arch? That is first arch. Mandibular nerve is a nerve of first arch. Topographic connection of ganglions, we are done with two ganglions. One was with the ophthalmic nerve, one with the maxillary, and two ganglions are topographically related to mandibular nerve. Another good question here is this one. The buccal nerve, only sensory branch coming from the anterior division of trigeminal nerve. It supplies the skin of the chin, skin of the cheek and mucosa of the cheek. And at times it pierces the buccinator muscle, but doesn't follow the Hilton's law, will not supply the buccinator. And everything about this trunk of mandibular nerve is important. What the only muscle of mastication, that is medial pterygoid, these two tensor muscle, topographic connection to otic ganglion, and that nervus spinosus. Now lastly, talking about this question, the question which was asked about otic ganglion, the question was about the relation of otic ganglion. Now I would suggest you that you just need to look into the atlas, and I would recommend Netter's atlas to you all, because all the questions in AIIMS, all the picture based question in AIIMS asked this time, all 4 questions were directly from Netter's. They were the direct images of the Netter's only. So I strongly recommend Netter's atlas for you, especially from the head, for the head and neck and neuro. What we've seen in last 2-3 years is that all the picture based questions in anatomy are from the head and neck and neuro only, and the pictures are directly taken from the Netter's atlas. So the question on the otic ganglion was regarding the relation of otic ganglion. So this is a schematic diagram. This is definitely not telling about the otic ganglion correctly. So let me just tell you the relation of the otic ganglion, guys. Otic ganglion, laterally we have mandibular nerve. Otic ganglion, if this is a mandibular nerve, otic ganglion is actually hidden medial to it. So otic ganglion, we cannot see it like this. Otic ganglion is on the medial side. So lateral relation of otic ganglion is mandibular nerve. Superiorly we have foramen ovale, anteriorly we have middle meningeal artery. I'm sorry, this is posteriorly we have middle meningeal artery, because middle meningeal artery is going through foramen spinosum, and foramen spinosum is posterior lateral to the foramen ovale. So posteriorly we have middle meningeal artery, and medially there is levator veli palatini muscle. Medially, that is, if this is a nerve here, and this is the otic ganglion. So lateral to the otic ganglion is the mandibular nerve, and medial to the otic ganglion the muscle is levator veli palatini. So these are the important relations of the otic ganglion which we need to remember. So with that note, let's take a small break, and I'll catch you back in 15 minutes, and we'll continue with the facial nerve there.